Good afternoon, everybody, and welcome to this afternoon's webinar, which is around navigating PSA results and unravelling urology's challenges. Before we go to introductions, I've just got some brief housekeeping points for everybody. Today's webinar is going to be recorded, and the slides from this and the recording will be uploaded to the Cancer Academy website, so it'll be available to view after the event, or for anybody who's not been able to make it, stay with your colleagues, if you could let them know that, please. On the Cancer Academy, you can find resources and recordings from previous educational webinars we've held. So if you haven't signed up yet to the Academy, then I strongly recommend doing so, because there are lots of resources on there. Your cameras and microphones have been switched off. There will be an ongoing opportunity to pose any questions through the comments chat section. So if you could please post your questions there, and members of the team are monitoring that, so we'll be able to pose the questions at the end of the sections of the presentation. So thank you very much, everyone, again for joining us today. My name is Dr. Catherine Butler, and I'm a GP in Chester, and I'm one of the GP place leads with the Cancer Alliance, covering Chester East and West. I'm joined today by my colleague, GP Dr. Rhiann Thomas, who is also one of the GP leads at the Cancer Alliance, and Rhiann covers Halton and Knowsley places. And Rhiann is very helpfully monitoring the feedback on the chat and the questions, so she'll be collating any responses to questions as they're posed, and also any questions that we don't cover in the main presentation. There'll be time for discussion later on. And finally, it gives me great pleasure to welcome Vishwana Panchanali to discuss PSA results and urology challenges. Vish is the Clinical Director for Urology and a Consultant Urological Surgeon at the Royal in Liverpool, and we're really, really grateful to him for presenting to us today. So thank you, Vish. Just in terms of the agenda, what the outcomes of learning from today, so this presentation is designed to give current urology data across Cheshire and Merseyside. There'll be some discussion regarding the urgent suspected cancer referral form. There's a description of the NICE guidance for the urgent suspected cancer referrals for bladder problems particularly, some primary care educational resources, common bladder questions, and then an opportunity for the open Q&A, which will be obviously the questions that you've posed in the chat. There'll then be a description of the NICE guidance for urgent suspected cancer referrals for prostate problems, common prostate problems and questions, and then another opportunity for your questions and an answer session. And then at the end of the presentations, we've got a further opportunity for open Q&A. And then we will bring it to a close, and we'll ask you for some feedback regarding the event. So thank you. So over to you, Vish. Thank you.
I think Sarah will do that. Yeah.
Hi. So my name's Sarah Griffiths, and I'm one of the I work for the Faster Diagnosis team, and I support the urology pathways. I just wanted to give you a bit of referral data really for urology. So we haven't split this down between referrals for prostate, bladder and renal. This is just the overall suspected urology referrals that the providers receive from across Cheshire and Merseyside. So between May 24 and April 25, the overall number of suspected urology malignancy referrals seen on a 2-week referral pathway was 12,603, which compared to 12,628 in the previous 12 months. So you can see some months there is an increase in referrals, some months it decreases, and that's down to normal seasonal variation. But you can see for the past couple of years, the referrals have been quite steady. Thank you.
Thanks, Sarah. Vish.
Thank you. Thanks, everyone. Good afternoon. Good to be here. Thanks to Catherine, Rhiann, and Sue and Sarah to organize this meeting to go through what couple of common topics which we come across day to day, and we felt that probably having a brief discussion with you and address any concerns or any points would be good. This is the standard referral forms which most of you have seen, and you use it on day-to-day practice, which includes covers for the prostate and also for the bladder cancers on the next slides where we go to. Next slide, please. Yeah, this is mainly for the prostate and the bladder one. Yeah, next slide. Thank you. Yeah, so we all know that bladder cancer is becoming quite common, despite smoking ban in the public places. We still have around about 10,000 cases per year, and it includes probably around 3% of all the new cancers. We still have, in terms of lifetime risk of 1 in 50 for men, and less than 1% of women chance of having bladder cancer. Next slide, please. When we look at the in terms of deprivation index, and that's one of the reasons why, being Liverpool and around in Cheshire areas, the incidence of bladder cancer is quite high. And if you compare it to the same deprivation area in terms of it's much more worse on the female side. There is 43% higher in females for most deprived areas compared to around 27% for men. And you can see that it's clearly on this map. There's more concentration around Liverpool, and then less so in terms of London around, and then around Newcastle around. So this is one of the topics which we need to be major address in terms of managing urological cancers. Next slide, please. When we look at the why we need to diagnose and referral pattern has to be correct is when we look at the stage 1 cancer, most of them can live, 5-year life expectancy is over 95%, and that drops down to nearly 50% for stage 3, and nearly around 30% to stage 4. So identifying them at earlier stage is quite useful, both for improve the overall survival and also the relative risk survival for both in men and women. More so in women, this is quite important. Yeah, thank you. Next slide, please. So what else we can start? Starting from not only diagnosing, we need to concentrate on what are the things which we can modify for our patients. Your role is significantly important in reducing the smoking and advising them for all the cancers. And if you look at following lung cancer in the picture, the second most important one has been the bladder cancer for smoking. So 50% of cancers are due to smoking, and there are benzodiazepines, benzidine and other beta-naphthalene, which have significantly gone down over the last couple of decades. One thing which is coming up new, which I might highlight, is a pioglitazone, which is used quite commonly in diabetic patients. In patients who have got a high risk, especially if they have a significant smoking history or any previous history of bladder cancer or bladder emptying difficulties, then they need to have a careful discussion when they are started on pioglitazone. Next slide, please. So how do we present? How do these patients present? Most of these are presents with hematuria, either visible or non-visible. Some of them we are seeing patients with presenting with a frequency, urgency, and nocturia, or more of a bladder symptoms. And similar to any advanced cancers, some of them they present with the loss of appetite, weight loss. Unfortunately, once it reaches that stage, they have a life expectancy between 12 to 24 months. So concentrating and regular referral of patients with hematuria, and in addition, if they have a recurrent UTI which is not settling down or not improving, those patients may be the better to be referred sooner as a 2-week referral. Next slide, please. So when we come to more in depth about the visible hematuria, so pickup rate is around 10% in these visible hematurias, finding some abnormality, and probably around 5 to 6% of finding cancers in these group of patients. When we go to non-visible hematuria, that goes down, pickup rate is less than 5%. There are some which confuse us with in terms of when we do the urine dip. Before referral, if patient is on vitamin C supplements, or if they have some hemoglobinuria or any other conditions or concentrated urine, they may have to be repeated before they are referred to the secondary center. Next slide, please. So this is one which was the initial slide. I expanded it a bit more in detail so that we can look. I think so. The current guideline suggests that anyone who is over 45 years of age, and if they have unexplained visible hematuria, which is without urinary tract infections. So if somebody has a UTI then and associated hematuria, it is advisable to treat them. And if there is persistent of hematuria after that, then they should be referred as a 2-week referral, and most hospitals will accept those as a referral. The other one is in men who are over 60 years, and if they have an unexplained non-visible hematuria or associated like a UTI or dysuria symptoms or a white cell, then as 2015 it was added as one of the referral criteria. When we go back to the newer thing which is happening is if they have a persistent or a recurrent urinary tract infection, which has been in the system for last 10 years, they should be referred as a non-urgent referral. Now there is a brief discussion among the urologists to see whether we will probably try to reduce the number of referrals which are with the non-visible hematuria. Are we missing a lot of cancers which are referred as a recurrent UTI? So whether there should be increase in such referrals. So that we are looking at the numbers to see does it make any sense in terms of improving or increasing those numbers. Next slide, please. So when we come to next bit is asymptomatic microscopic hematuria, patients who did not have any symptoms, but as a part of routine check, they have a microscopic hematuria. What do we do then? If they are up to 60 years, the chance of finding something abnormal is very low, less than 0.75, 0.8%. But the same thing goes up to 1.6% if they are over 60 years. At this point, the suggestion is for they don't need urgent referral. But recently, I think you might have just seen there is advice and guidance referrals which have come through the GERFT Academy. What they are looking at is men who are younger than 60, and if they have a asymptomatic microscopic hematuria, they probably should have an evaluation in the form of EGFR, ACR ratio, and find out whether do they have any high risk of developing cancers in terms of developing renal failure. Then they should have a probably bit more detailed discussion about that, and then referral as appropriate. I put it in the next slide. Next slide, please. Yeah, so this is the one what I was mentioning. If they are younger than 60 years, this is the new thing which is coming in through the GERFT Academy. They should have a serum EGFR. Some of the patients, if they are referred to us as a routine referral, we might send them back with advice and guidance, suggesting that having a EGFR, urine dipstick for proteinuria, and blood pressure measurement. If they are any of them are if all of them are normal, then there is no need of referral. But if they are abnormal, or if you find for some additional symptoms, patient had an ultrasound which shows abnormality, or if they have a high risk of bladder cancer in the form of family history of bladder cancer, or if they are ongoing recurrent UTIs, or they are incomplete emptying, then they may need a refer to the urology to assessment of those symptoms. And as general, you are better at assessing the nephrology assessments in terms of their long-term risk of chronic kidney disease. Those need to be done and managed accordingly. Next slide, please. So what happens once the referral comes to us? We do a general straightforward assessment. If there is a non-visible hematuria, they have an ultrasound scan and a flexible cystoscopy, which tells us what is the diagnosis. And then next bit, what we do is for the visible hematuриas, they usually have a CT urogram as they have a probably 2 to 3% chance of having an upper tract cancer. So in addition with the flexible cystoscopy, which has been the standard pathway, but there is a growing, we are exposing many men or women to the CT scans. So we are exploring nationally through GERF Academy and other, see whether if they have a low risk of developing bladder cancer, and if they are younger than 60 years, those could be potentially managed just with an ultrasound scan initially. But watch the space. The current guidance suggests that they should have a CT urogram if they have a visible hematuria and a flexible cystoscope. So when we do the TURBT, following that diagnosis, they have a TURBT where it is done under general anesthetic with the resectoscope, and then we have a control the bleeding. Most of them nowadays, they are done as a day case, and depending on the histology, we manage the further plan. Next slide, please. So this is probably the staging more appropriate for at the hospital setting, but just to give a brief input, up to T2 can be managed, up to T1 are with these corresponds probably around 90% of our cancers, around 10 to 15 are T2 and above. So up to T1, they could be managed endoscopically with mitomycin and cystoscopic surveillance. But if it is T2 and above, there is a combination of radiotherapy or cystectomy, or they need to have. Next slide, please. So this is what we do after the TURBT. Most of them have either mitomycin or epirubicin, which at the end of the surgery, we put a catheter in and put this chemical agent mitomycin, which usually kills out any cancer cells which are about to be implanted. And this has shown that there is a 30 to 40% reduction in the cancer recurrence if we follow this within 6 hours of the TURBT. So, most centers do it at this time of the surgery. Next slide, please. So this is the staging. Again, as I said, if they don't have a cancer which is gone into the muscle, that is what we call as a non-muscle invasive bladder cancer, NMIBC, that is divided into low risk, intermediate, high risk, and very high risk. Next slide. If they are at low risk, then what we do, as I said, mentioned TURBT and some sort of chemotherapy. Next slide. If they have intermediate risk, they may have an additional chemotherapy with a catheter for 6 weeks. Next slide. If they have a high risk, that's where we add them with the BCG. But there is a move towards giving them intravesical immunotherapy. There is a lot of trials coming in, which might change, because still, despite BCG for 2 to 3 years, around 30% still do not respond, or they grow further. So we need to see whether how we manage these. And with the immunotherapy has been coming in, like similar other cancers, that is coming into this picture to support us. Next slide. And if it goes to very high risk, that goes into more of a upfront radical cystectomy, which we may do along with neoadjuvant chemotherapy or sometimes on its own. For the last 5 years at Royal, we are doing all of these robotically. Hospital stay has come down from, I managed to get it down from 14 days to 4 days, which has been remarkable in terms of the hospital admissions and discharges. Most of them recover back quickly. It used to take nearly 3 months for them to get back to their normality. Most of them are getting back within 4 to 6 weeks to get back to their normality. Yeah. Next slide, please. Yeah, so this is about the muscle invasive bladder cancer. They have a neoadjuvant chemotherapy, radical surgery, and then some may need adjuvant therapy. that neoadjuvant could be with the chemo or immuno or different treatments. If they have a locally advanced, then they will go for more to the oncology side to have the immunotherapy or chemotherapy. Thank you. Next slide, please. Yeah, so this is probably the Action Bladder Cancer, which is there are two bladder cancer charities which work collaboratively, and they have got a lot of information. So whenever the patient is diagnosed, we do use their support, these charities, to guide them in their journey, starting from collaborating with other patients to support both financial, medical, or physical, or any other support they need. Yeah, thank you.
Thanks very much, Vish. We've got some questions already posed here for you, and then if there's anything else in the chat, I know Rianne's been monitoring that. So based on what you've said, should urine be sent off for cytology as a way of by way of a screening test for patients who are presenting to us with recurrent urinary symptoms? What are your thoughts?
That's a very interesting question. Even for urologists across the country and world, we do have this, query whether the cytology, how useful it is being. But over the last, couple of decades, it has been proven that cytology probably is useful in a selected group of patients where we are having a persistent hematuria, but we don't have any clear tests, clear results on examination or cystoscopy or CT urogram. In those scenarios, it is useful. But to answer your question, in a general practice setting, I don't think there is any role for cytology at this moment.
Thank you. And patients with hematuria symptoms that don't fit the criteria for an urgent suspected cancer referral, such as a younger patient with pain where you think it's more likely that they might have renal stones, what should we do with those patients?
Yeah, so we do have some patients who present with the loin pain, and when there is a dipstick hematuria, in those patients, as if they don't have a very high, they are not very high risk for bladder cancer. I think it's common sense, but my suggestion is probably they should have investigations to rule out renal stones in the form of ultrasound or a CT, depending on the severity. And if hopefully that will give an answer. As it is a microscopic hematuria, I'm assuming in these ones probably will, over month or two, they will, if there is a bladder cancer in minority of patients, they will continue to have bleeding, and those could be referred at that point if they are persistent hematuria, but those will be very minority. So I would probably go for investigations of the stones if they have a loin pain associated.
Thank you. And a perennial question for GP. What's the best way to manage and investigate microscopic hematuria?
Yeah, this is one, GERF and along with the BAUS, where I chair the oncology section, we've been looking at it carefully. Even hospital settings, we do have, a lot of patients coming as a referral, and we want to reduce that burden for you all, for us, and for the NHS. So what we are looking at is currently is in men who are younger than 60, where the chance of if they have an asymptomatic hematuria, the risk of finding cancer is less than 1%. Those potentially be referred, as I mentioned, with the EGFR, ACR value, and if those are fine, then they should be, they don't need any referral, just a monitoring of that. Beyond 3 or 6 months, if there is a persistent of microscopic hematuria, that's the point where we would like to see them in the clinic.
Brilliant, thank you. And with recurrent UTIs, what are the treatment options and the newer prophylaxis options for these patients, especially in particular age groups?
Yeah, so we normally, recurrent UTIs, we divide into perimenopausal and, premenopausal of those ones. If they are perimenopausal, and then we do, with regard to the referrals, they need the ones which are persistent and associated with hematuria, they will go into as a 2-week referrals, but the remaining ones need as a routine referrals, which we are seeing them as a part of diagnostic pathway nowadays. Liverpool with Miss Ham has been set up a very good diagnostic pathway. They directly come for a diagnostic cystoscopy rather than coming to the clinic. That way we are absorbing them. To answer your question, like most of these, there is a newer treatment which is the hyperamine and mefenamine hippurate, which will be has been quite useful and nice approved in patients who have recurrent UTIs, which are resistant, especially to avoid the more resistance organisms. So we tend to give them, it's 1 gram BD, that's one of the dosage. Most of the Ts will need a rotating antibiotic regimen for 3 to 6 months, along with estrogen cream, possibly, or other support, which usually resolves their infections. If they do have some incomplete emptying or something, then we do manage them with the intermittent self-catheterization or dilatation. Thank you.
Thank you. Rhiann, any questions or comments from the Q&A box?
Hi, thank you. There's a couple of questions. I think you've addressed some of these already, Vish, in the questions you've already answered, but just in case there's anything you want to add. One of the questions was around the pickup rate you'd mentioned for microscopic hematuria being between 2 and 5%. So asking why it's not in the urgent suspected cancer guideline referrals in that case, given the usual 3% cutoff. I know you alluded to some of the specifics around different groups and their different positive predictive values, but I don't know if there's anything else you wanted to add on that.
Yeah, so I think the initial bit what I gave is for whole of microscopic hematuria, and that has been subdivided into younger than 60 and more than 60 years, where the PPV goes down significantly lower to around less than 1%. So those groups usually don't need. And when it comes up to 1.6%. So overall, initially, when we look at that, may be a bit of that slide, may be the bit of older data, I think. But the current one, it says that 1.6% for men who are over 60 years, and it is 0.78 or 0.8% who are younger than 60. So those won't need a referral as a 2-week referrals. Yeah.
Great, thank you. And then there was another question around, would you routinely do an ultrasound scan in those patients with the non-visible hematuria that are under 60? Yeah,
so we did have a locally, there is, I mean, as I mentioned, the GERFT and other burst did, along with the BAUS, they did a big assessment of all these hematuria patients, and the pickup rate, I mean, the one data what we are using it quite, nice guidance and other guidance which we're using it probably 10 to 15 years old, but the recent data and also improvement in the ultrasound findings and ultrasound technology, the chance of missing the upper tract cancer is going down slowly. So we are exploring those. And I think when we had a meeting with the Cancer Alliances, it was provisionally agreed that probably a couple of centers like Arrow Park will try to pilot this. So I'm not entirely sure whether they have piloted it at this point. In a selected group of patients who are a visible hematuria and not very high risk for developing bladder or upper tract cancers, they are going a pathway into the ultrasound and a flexible cystoscopy rather than as a CTO.
And then I think there was a further question about the longer term management then of microscopic hematuria if the provisional tests in primary care are normal. I think you've addressed that in answering Catherine's questions. But the other question was around, is there a role for digital rectal examination in assessing these patients in primary care?
Yeah, so that has been again difficult in terms of the secondary care. Primary care, I'm not entirely sure whether if the patient is being referred, but as a part, if they're asymptomatic, digital rectal examination itself doesn't have any role. But if they're symptomatic with regard to lower tract symptoms and to assess the prostate or to rule out, very rarely some unusual prostate cancer or something, then they may benefit. But mainly to assess their lower tract symptoms, digital examination forms a part of it, but not if they have just non-visible or visible hematuria on its own.
That's great. Thank you very much.
Thank
So
you.
I think if there's any other questions anyone's got or anything from that we haven't answered, please do add them in the Q&A section and we can follow up on them afterwards if we haven't had time to cover them here. But otherwise, thank you. Back to you, Vish.
Thank you. If we could go to the next slide, please. I've started with the prostate cancer referral. So this has been the current referral guidance, which suggests that in men who are over 50 years, and if they come for PSA check, they should have a PSA. They should be offered PSA after counseling and referred accordingly. If the patients have a significant lower tract symptoms or erectile dysfunction or visible hematuria, again, the PSA and the rectal examination should be offered. The patients currently, there's been a lot of debate going on in terms of what PSA value should be taken into practice. Nationally, we are still debating about this, but at this point, the current guidance suggests that in men who are over between 40 to 50, the PSA up to 2.5 is normal. And if it between 50 to 59, if it is more than 3.5, those are the guidance which are being put into the NICE. We have asked NICE to review these with the current evidence, which they have agreed to have a look probably in the next 6 to 12 months to update the guidance. Next slide, please. So yeah, why prostate cancer? And I think we all have seen the more number of professionals and important people diagnosed with prostate cancer, we have seen referrals going up. I was surprised to see that when Sarah showed the referrals, it has been more or less quite steady. But at least in the hospital setting, we have seen that probably 5 to 10%, at least up to 20% increase in the referrals during that time when they are referred. So these are quite important figures, and the recently been Sir Chris Hoy, who has who strongly believes that there should be some sort of screening for prostate cancer, especially in patients with family history and other things. So let's watch the space and how we go forwards. Next slide, please. So at this point, over 55,000 patients are diagnosed annually, and this is going to increase to nearly 85,000 by 2040, which has been gradual growth of around 1.6% to 2% over the last couple of decades. Next slide, please. This is the National Prostate Cancer audit group who collects all the data across the 4 continents, and we have seen that there are around 19% of men are diagnosed with metastatic cancer, and when we look at the men who are offered the radical treatment for high risk groups, that is still around 69%. When we go to the stage, depending on the ethnicity and age and all that, when they're more than 85 years men, white men, they are diagnosed with 9 out of 10, they're diagnosed with stage 4 cancer. We know in men who are over 80, they do have a higher risk of developing cancer at that age. Yeah, next slide, please. So this is a quite important slide. As you can see, when they're similar to bladder cancer, but not as aggressive as bladder cancer, the prostate cancer, the 5-year survival goes down to nearly 50% once it goes to stage 4. And when you look at into the the proportion of patients which are diagnosed at different sections, stage 1, 2, 3, 4. Despite our attempt, it hasn't changed. Still over if you look at this 29 plus 17% in 2022, still around 40 to 50% are diagnosed as stage 3 or 4. That's the reason I think we need to do something more than what we are currently doing. Next slide, please. So also, if you look at the health equity, compared just from London to Scotland, although this figure is a bit different, the 35% of diagnosed, that is probably what we're talking as a metastatic or aggressive stage 3 or 4 cancer. I think it has been debated. It's probably around 20-25%, but it's still quite high compared to better living conditions areas in London and Southeast. So there is a difference between the equity of access and the cancer diagnosis. Next slide, please. So when we look at the health equity challenges, the age itself, like between 70 to 74 years, if it is, they have high chance of prostate cancer. Ethnicity, as we all know, 1 in 8 men in general for Caucasians, but when we go to black men, it is 1 in 4, and in Asian is a bit more lower at 1 in 13. Deprivation, as I mentioned, there is many more patients are being diagnosed with at a low deprived areas, even including in white or Caucasian men in that way. There is the family history. There is nearly 2.5 times increased risk of prostate cancer compared to without any family risk, and similar there is 5 times risk if they have a BRCA2 mutation. Next slide, please. What are the current guidelines suggest? In men over 50 years, they can come to general practitioner to request for the PSA test. Then in men who are more than 45 years, if they have a strong family history, they can come and ask for the PSA. And if they are carrying a BRCA gene, there is a debate between 40 to 45 years, they can come to ask for the PSA. Next slide, please. This is the guidance which we went through briefly at the start. Next slide. So this is one which we, along with the Prostate Cancer UK, we felt that the rectal examination in some patients are not coming forward for PSA check, especially patients from poor socioeconomic status, Afro-Caribbean men who are not coming forward with the fear or anxiety about the rectal examination itself. And this was shown in the PCUK and the BOWS assessment which was done. So what we felt that in patients who come to you for the to check about their risk of prostate cancers, they should have an open access to have a PSA test by itself. And if the PSA test is high, there is no need to do the rectal examination. They could be directly referred to a specialist center for further investigation. Yeah, that was our aim, to highlight this and to raise it across the country. Next slide, please. So as we all know, men who have had a vigorous exercise or ejaculation, it can affect the PSA to some degree, especially if the patient have had an inflammation of the prostate due to strong voiding or infection or bike riding or some of the other reasons. Then these could make it a bit more higher. And once you have abnormal PSA, it is very difficult to manage that. So if it possible, avoid 48 hours before repeating the PSA. Next slide, please. This is the EAU guidelines, which is similar to what the PCR guidance, what is there currently, and they have looked at the evidence across the world, and they feel that there is a strong evidence to support what we are doing in men who are over 45 years, 45 years with the family history and Afro-Caribbean descent to have a PSA test at that age, and other men over 40-50 years and with the BRCA gene mutation to have start having a PSA if they need a request at 40 years of age. Thank you. Next slide. So this is the information booklet or a guidance, which is there probably with most of you. Just gives them a patient what to expect, what they need to do, what are the benefits of PSA test, what are the negatives of PSA test, and what's the chance of finding cancer. So this gives them a brief outline about and it is available on the NHS UK website. Next slide, please. So there's been a big debate in terms of whether screening, what sort of screening we should do. We should do screening for all or screening for high risk group, as we mentioned, Afro-Caribbeans plus family history or patients with the BRCA gene, or we don't do screening. So currently, the standard guidance from the National Screening Committee suggests that they need to fulfill these Wilson and Gender criteria. And I feel we are very close to this, especially for high risk group. And there is a similar consensus from few of the team across the region. Next slide, please. So these are the few prostate cancer screening trials which have been done. And when you look at more defined data, refined data, so the two big ones were the ERSPCs, is European Randomized Screening for Prostate Cancer, which was a long follow-up of 16 years, and they had a PSA test cutoff of 3 milligram, and they looked at to save one lives, you need to screen 570 and 18 might need additional treatment. But that number is going down with the high risk group and more detailed approach. Yeah. Next slide, please. So with all that data, the European, the urology team have introduced a more of a risk-based approach for screening. So they have introduced in probably around 10 to 12 countries, and each country is assessing different aspects. So one country is assessing whatever model we use, is it good for screening? There are a few centers who are assessing the pilots. Some centers are looking at the evaluation and sustainability and cost effectiveness. So hopefully they will give us in the couple of years some info whether is screening good and how useful it is in our current context. Next slide. So I don't know, some of you might have heard the Prostate Cancer UK and Prostate Cancer Research, two big charities in the country, along with BAUS and other stakeholders, having a good chat with the Parliament to see whether is there a way and can we ask the National Screening Committee to look at this once again. So there was all Parliament APPG was set up for prostate cancer. We had a meeting, third meeting yesterday, and in the Parliament, which I've attended most of them. There is a lot of discussion about how useful it is. Is it going to cause more harm? Is it going to cause more anxiety for men? So we're looking at all those aspects, and hopefully we'll have some answer towards the end of this year. Next slide, please. And the PCR prostate cancer research has done some assessment in terms of physical, psychological, social, and other aspects impact on the screening. If it is introduced, how much benefit it is and how much risk it is overall to. And current analysis shows that if we do it for high risk group, the benefits outweigh the risks in terms of both financial and physical. Next slide, please. So this is the following the meeting. We felt that the evidence for currently for screening is still not fully there, and sometimes it is very difficult to do a randomized full trial for prostate cancer screening, because once we introduce a patient for screening, some of them they will some patient though they shouldn't have in between screening PSAs, but most of them they will go and have another PSA because of the anxiety. So that has been a bigger barrier, and that has diluted or made a mix of all these, the screening trials, couple of them. And so what we felt as a BOWS after discussion with the members and also the exec committee, we felt that nationally there should be some sort of risk stratified early detection program. Even if we don't or evidence to introduce it for whole screening, we need to look at what sort of PSA thresholds we should have. How can we educate men to come forwards for PSA test, and what improvisation we can do for MRI protocols and the biopsies to come to this next level. We know that the National Screening Committee is looking at it, and they have asked one of the public health body in the country to gather the evidence and tell them. So hopefully the Parliament will announce along with the all the stakeholders towards some end of this year whether there are three options. One is no screening, enough evidence, enough financial support, and will continue as we are. The second one is a screening for high risk group, and the third option is full screening. I don't think there will be appetite from or evidence to do the full screening, but we'll have to wait for the National Screening Committee to come up with a final conclusion in this. Yeah. Next slide, please. So this is the standard coming to what happens for the evaluation pathway. Sees a GP, has a PSA, comes to urology triage, which most of them we do on the telephone. Then we have an MRI vetting directly, and then they have the biopsies, and then the treatment decision is done. By introducing nurse-led triage and a direct to MRI, we have speeded up our process of diagnostic pathway over more than 3 to 4 weeks. Next line. And this is the MRI picture, why MRI is useful and why rectal examination might give a bit of false assurance for some patients, because around 10 to 15% of cancers are predominantly anterior. And if somebody has just rectal examination without a PSA, that could give them a false assurance that, oh, there is no cancer, but they could have a potentially aggressive cancer in those group of men. Next lines. There are trials which are ongoing in terms of assessing whether can we use the MRI itself as the screening tool, or in addition to there's Mr. Padani, Dr. Padani and Hashim Ahmed. They have done a few trials on MRI as a first spot to do the PSA screening. Next slide, please. So what happens? They come in, they have the MRI, and then we do the previously we used to do transrectal, now we do the transperineal biopsies, which is significantly reduce the rectal infections risk, and we are able to do it under local anesthetic, which I introduced just around COVID time. Next slide, please. And this is the flow rate or a flow diagram for the prostate biopsies. We do assess if they have a life expectancy of 10 to 15 years. This is quite important, especially at the at the GP surgery level. If somebody has a life expectancy of less than 10 to 15 years, I would just counsel them and tell them that the risk of having the PSA and finding a cancer is not useful in those groups. So if they have a life expectancy of more than 10-15 years, then they should have a PSA. Then they go for PSA, then risk stratified. If the PSA and MRI DRE is low, life expectancy is low, then they could simply have a individualized follow-up in the form of low risk or high risk and MRI at the start, and then they have the biopsies. Next slide, please. Yeah, and I think there are newer tools, but none of them have been used as a screening tool at this point. Some of this may be useful if we do an MRI, like similar to how I mentioned in patients who have a persistent microscopic hematuria. In the same way, if somebody has a persistent PSA high, then they could have these biomarkers to reduce the chance of accuracy or we getting a bit more accurate understanding of whether the patient has a chance of prostate cancer or no. Next line, please. Thank you.
Thanks, Fish. Just a few questions for you now, please. So after, obviously, that's quite a detailed discussion there. So what are the pros and cons of PSA testing at the end of all that?
Yeah, I mean, again, what we need to look at is the first and foremost is if somebody has a life expectancy less than 10 to 15 years, then I don't think they should have a PSA test. They should have a brief counseling, and because we're not going to treat them. So even if they have a PSA, they're referred to us, they have an MRI, and then we don't do anything them, just monitor them. So unnecessary for patient and everyone. So the next bit is about what are the pros and cons. If they do have a high risk population group like family history or Afro-Caribbean, then there is a very strong chance that we may be missing aggressive cancers. So those groups, I would surely recommend them to have a PSA. What are the cons of having a PSA test? What main thing is what I said is if they're not fit enough, then they could have an unnecessary, tests, including biopsy. So that's what I hope I've answered that well.
Yeah, no, that's great. Thank you. And in that vein, how would we manage an elderly or a frail gentleman who has a mildly elevated PSA? We do.
That's again, so the recent advice and guidance document which has been released by the GOV that clearly defines these ones. If they have if they have more than 10 to 15 years life expectancy, and if their age is over 80 years, if they are reasonably fit and more than 80 years, then those patients potentially could be just monitored with the PSA, because we'll intervene only if they have a metastatic prostate cancer in those. But on the other hand, if they have a higher, very frail and life expectancy less than 5 years, again, we won't advise any further investigations until they develop metastatic disease.
Okay, thank you. What's the suggested monitoring regime for the PSA?
That's probably a holy grail question. It's very difficult. So what we are doing from clinical side is, if somebody say you have referred a patient to us for a suspected prostate cancer because the PSA was high, what we tend to do is after doing the MRI and the biopsy, if it is negative, then we are sending a letter. The chance of them having prostate cancer is extremely low if the PSA density is less than 0.2. So we are sending a letter in the form of, if their PSA density, whatever the PSA value comes up to take their PSA density over 0.2, we give that letter that if the PSA goes up beyond that, then kindly re-refer. Again, taking those precautions, avoid cycling, avoid ejaculation prior to those, and regularly assess. If men who are 75 years, we need to spend more time to assess them before we request a PSA or continue monitoring PSA beyond that age. Thank you.
And what effect does finasteride have when we're monitoring the PSA?
Yeah, so finasteride or dutasteride, which are 5-alpha reductase inhibitors, which usually are given for patients with larger prostate, more than 30 grams, and they have a lower uterine symptoms. Once we start them, if they have and if they have been on for more than 6 months, then the general agreement is that that reduces the PSA value by half. So if somebody who's on finasteride for more than 6 months, and if the PSA is 3, the actual PSA for them is 6. So accordingly, we need to put it into the age-specific criteria. And if it is high, they will need a referral or regular monitoring at that point.
Thank you. And are there any particular advances in prostate cancer treatments at the moment?
Yeah, I think the prostate cancer is probably one of the cancers which that's one of the reasons it is very difficult to follow one sort of treatment regimen. So a couple of things what I can mention to you. Surgically, there is nuances in terms of, so from our side at Royal, is the first NHS hospital in the country to have a single port robot prostatectomy service. So myself and one of my colleagues, Mr. Weston, are doing those. From radiotherapy, they have recently introduced where they are doing the radiotherapy with a shorter regimen and without any hormone treatment. And in addition, there are other treatment in the form of focal therapy, cryotherapy, which are still done. The other last two, which I mentioned, are still done as not as a part of clinical trial. They have been offered, but as a part of because they don't have evidence beyond 10 years, so they are done as a part of observation or assessment.
Okay. And just to sort of sum up, really, because obviously there's lots of discussion going on, what's the current position on a prostate cancer screening program, would you say?
Yeah, so currently, as we stand, there is no prostate cancer screening at this point. But personally, plus through the BOWS and from charities, we feel that the current stance, what is happening of patients over 50 years can come and request PSA, is not helping us to reduce the chance of finding cancers which are advanced or metastatic. So something needs to be done. So where do we stand? It is quite difficult, and we don't want to. We feel that something more needs to be done, which could be starting from educating high-risk men coming forward for PSA. More education in terms of which patient should have a PSA, which patient shouldn't have a PSA. The next level, which patient should have an MRI, what's the PSA cutoffs? All those, something has to be done better, because one of the NHS forward plan, which was introduced a few months ago, it suggested that the cancers which are metastatic or advanced, we need to reduce that percentage to 25% or less. And unfortunately for prostate, still there are 40% of cancers which are diagnosed either at advanced or metastatic. So current stance, what we are doing is not right. The prostate cancer screening, some sort of more than what we need doing is necessary. The National Screening Committee is looking at prostate cancer screening, and we are debating this with in the Parliament and everywhere. So until that comes in, and our ask is, if they do suggest that probably high risk group screening comes in, then there will be a discussion with all the GP leads to see how it is introduced. And like other all screenings, it is not going to be imposed without any financial resources. So there will be financial resources, support, and workforce planning will have to be done. And those are the things what we are parallelly looking at to see how we can ensure that if they do suggest that screening, we can bring those along with that. Yeah. Thank you.
Thanks for that. Rianne, have we got any questions or comments in the Q&A box, please?
Yeah, we've got a couple that I think are specific ones that we haven't addressed yet. One was around, should we be doing a baseline PSA on men who start finasteride so we can then see if there's any significant increase?
It's a very difficult one. That's a quite valid questions. So one of the things what it is suggested is if somebody comes with the lower urinary tract symptoms, and if they are over 50 years, there is an indication their symptoms may be due to prostate cancer. So before we start on finasteride, for that reason, some or most of them may have had a PSA. But if somebody is starting on finasteride on its own, that itself shouldn't be an indication to do a baseline PSA.
And then there's another question along that line around the finasteride use. Around, are you aware of any differences in side effects from single use of tamsulosin and finasteride, or a combined pill with tamsulosin and dutasteride?
No, I mean both dutasteride and finasteride work in the similar way, and we haven't seen or there is no data to suggest that they should do it work differently. The effect from prostate volume reduction It's similar for 5 milligram of finasteride and 0.5 milligram of dutasteride. So combination medication, I don't think they should have anything different. Yeah.
That's great, thank you. I think that's answered all the other questions that were in the chat. And again, I know there were some multi-part questions, so if there's anyone feels their question hasn't been answered, please let us know and we can pick that up afterwards. I'll hand you back to Catherine. Thank you.
Thank you. Thanks everyone for all your questions and comments. There's been some really interesting points and queries raised there. A really important part of the webinars and education that the Cancer Alliance does is that we can collect some evaluation from you to support future planning and delivery of educational topics. So we'd be really grateful. We're going to just pop a link into the chat and it will also be emailed to you, which is an evaluation form which has got some questions which we'd really appreciate if you had a moment just to feedback some comments there. That would be very helpful to the team. Thank you for that. And finally, as we did mention at the beginning of the recording of the webinar is going to be available to you and a copy of the slides. It'll be uploaded over the next few days to the Cancer Academy, so you'll be able to access it at a later date. And there'll also be a summary document with the key learning points and a link to the resources that have been mentioned in Vish's presentation. I'd like to thank you very much, Vish, today for taking the time to come and speak to us and share your expertise with us. It's a really interesting topical area, especially around PSA testing, so it'd be interesting to see what the future holds and hopefully give us some clearer guidance in primary care. And I hope that you've all found it really useful and informative. I know I certainly have. And thank you, everyone. I know everyone is very busy, so thank you everyone for joining today. It's been a really good session. We hope to welcome you again to a future Cancer Alliance webinar or event in the very near future. Please keep your eyes on your emails and your local place bulletins as well, where we share details of the up and coming events and also on the Cancer Academy. And thanks to the wider team who've all supported and made today possible. So thank you once again, and you'll receive all the resources shortly.
Thank you, everyone. Have a nice afternoon. See you. Bye-bye.